Okay, welcome to our webinar, which is the fourth in our virtual nursing learning series, introducing the expert oversight telenurse model. And I'm very excited to present with my co-presenters today from University of Colorado Health, UC Health. And let me just introduce them quickly and then provide a little context. So we're together with Dr. Himali Patel, and she is an associate professor of medicine at the University of Colorado Anschutz Medical Campus. She completed medical school and residency and chief residency at the University of South Florida, followed by a fellowship in academic hospital medicine at the University of California in San Francisco, focusing on quality improvement. And UCSF is like the mecca of hospitalists, so that's a fantastic fellowship. She is currently the Associate Chief Medical Officer for Inpatient Services at University of Colorado Hospital. And her main interest in health systems redesigned to improve quality of care and efficiency in order to drive strong patient outcomes and a culture of safety, as well as outstanding patient, provider, and staff experience. So we're going to be touching on a lot of those today. And also, I'm very happy to have my friend and colleague, Amy Hassel. She's a seasoned healthcare professional with over 15 years of experience as an ICU registered nurse, currently serving as a senior nursing director at UC Health Virtual Health Center. Amy leads a team that elevates patient care through the UC Health system with her innovative strategies and commitment to excellence. She continues to make significant impact on the healthcare landscape, driving positive change and improving patient outcomes. And I'm very excited for them to share about their program today, which is comprehensive and been many years in the making. So they will be covering today, starting with their virtual sitter, or they call the safety observers solution, as well as their sepsis and deterioration program done virtually, and their virtual deterioration, which is kind of a marriage of the rapid response nurse and the expertise of a virtual nurse. All of that improving patient outcomes in a very measurable way, and just a great way to be doing virtual nursing, and starting way before the pandemic. So, and we'll get into that. But before we do, I just want to kind of get a little feel of where we're at with those that are listening. And so let's start with a poll about, we'll run that first poll for those on the line. Which of the following are you struggling with that virtual nursing could help with? Novice nurse mentorship, and we know there is a complexity and experience gap. The patients are more complex and nurses are less experienced. Overseeing the complex high-risk patients, establishing and following checklists and protocols. We will be talking about sepsis protocol today, retaining experienced nurses or other. And just a little spoiler alert, there's a pre and post. So at the end, we're going to see if after hearing what's been done at UC Health, you're thinking any differently about in which ways to apply virtual nursing. All right, let's go ahead and see what we found. Okay, kind of evenly split on both ends of the nursing spectrum. How do we support those novice nurses, and how do we keep the seasoned, experienced nurses? And I think that virtual nursing is something that can absolutely help with both. And also just really looking at that quality and safety aspect as well, and some others. And feel free to just use the questions or chat to make comments or questions. And I'll be monitoring that as I kind of hand it over. And then we want to run one more poll. And this is more about where are you on your virtual nursing program. So interested enough to take an hour out to spend with us. but where are you in the, it's already implemented, you've got a program implemented, or are you in that piloting phase? Or are you, and we're assuming you're at least conceptualizing because you're here. Oh, wow. Okay. And I think this will help Dr. Patel and Amy to get an idea of where our audience is coming from. So the results show that most start in that planning and conceptualizing phase. So this is your chance, Amy and Hamali, to impact how a lot of different organizations plan. Some are in the middle of piloting and some have already implemented. And I recognize some of your names, and I know that you, some of you on the line are implemented different types of virtual nursing. And I think it was the second session that we were talking about more of an admission discharge med-surg focused. And this is more of a expert oversight focus today. So before I hand it over to Amy and Dr. Patel, I just wanted to share with you two survey questions that we got from our market research that we did, that we commissioned very recently in April of, and we had almost 800 leaders, healthcare leaders respond. And it was focused on virtual nursing. It was done by Jocelyn Insight, who does the market research for AONL, ANA, and the Daisy Foundation. And this one was like very validating to me. Only 1% of the respondents did not believe that virtual nursing would become an integral part of care delivery models in acute inpatient care. And that's the setting we're focusing on today. So 2/3 said yes, absolutely, and only 1% said no. And I'm sure that 1%'s not on the call today. And then the next slide, so GoToMeeting limits, we could only put about 4 options up. So weren't able to put all these options up, but that here are the reasons that are important metrics that the respondents in the market research thought were important for measuring success. And so that's improving quality outcomes is very high, and patient safety is very high, as well as the workload and satisfaction for nurses. So I am going to hand it over to Amy and Dr. Patel, and just excited to hear your story of implementation at UC Health.
All right, well, thank you, Elizabeth, appreciate it. I'm gonna kick things off. So as Elizabeth introduced us, I'm Amy Hassel, and Dr. Patel will be presenting here in just a little bit. I'll hand it off to her, but it sounds like most of you are on the journey of conceptualizing, and Elizabeth actually asked me to kind of share a little bit about our story, you know, in hopes that maybe it will help others. And so I'll just take a couple minutes here and kind of outline how we started to add on our service lines. And I'll just add that the virtual health center that I oversee is a remote kind of clinical command center. So we started this journey back in 2016, as you can see, and this is actually a shot of our academic campus. So UC Health is based out of Colorado, all up and down the Front Range of the mountains, and there's about 12 hospitals in our healthcare system, and actually we just added an additional location, so there's now 13 hospitals. So it's a fairly small healthcare system, about 2,000 inpatient beds. So just to kind of give you some context of who we are and how we're set up. So when we started the virtual health center back in 2016, it was very based on the fact that we were building 3 new community hospitals of our 12 hospitals. So Colorado is kind of in a unique spot where we continue to grow and add on a lot of state population volumes. And even post-COVID, we continue to just massively grow in a population. And so we continuously have waits in our ED, you know, capacity challenges, and it just doesn't matter where you are in Colorado, it's getting fuller. And so when we set up our remote command center, we focused on 3 basic service lines that could help serve our community hospitals, but also be a platform to help serve all of our healthcare system. So we centralized or started laying the groundwork to centralize telemetry. We looked to add on a telesitter program at that point. We did not have that capability prior to that. And so we went through a vendor selection process and obviously picked AvaSure. And then we stood up virtual ICU for our 3 community hospitals because they were not going to have the staffing luxury of having an intensivist at night. And so I know many of you have probably, done EICU work or been a part of that yourselves, but those were kind of the 3 service lines we chose to go out of the gate and kind of lay our stack of services on. We had virtual visits stood up in some kind of rudimentary fashion, to be honest, with telehealth. And then we had a decentralized virtual urgent care. And so that really didn't come into the command center until later, but important to our story. So that was kind of how we started the journey. We started scoping things and workflows and what that would look like. And so if you could go to the next slide. If you fast forward to 2023, and then we'll go further in just a minute, but we've added on quite a bit more to our portfolio and things that we're doing. And of course, COVID was a catalyst to a lot of this work, but to be honest, we were doing much of our virtual sepsis work that I'll talk about prior to the COVID pandemic. And we had centralized our virtual urgent care, but to give you some idea of how much things exploded during that time, we, on the fly, stood up remote patient monitoring, Dr. Patel, myself, and others across our healthcare system for diabetes, for home monitoring post-COVID hospitalization, and watched almost over 1,000 patients in the home setting during COVID. And our virtual visits for our virtual urgent care went from 30 a month to about 300 a day, about 200 to 300 a day, depending on the day. So it exploded overnight, and we really saw the visit volumes just go through the roof. And so we've added on all these different programs and technology, but we've really tried to make our command center a pivot for safety, clinical outcomes, and scaling expertise resources. As we know, healthcare, I think we were kind of in the boat with all our challenges before the pandemic, where healthcare redesign was already kind of upon us, and then obviously is all upon us post-pandemic. If you go to the next slide, this just kind of highlights where our marketing folks helped us. Is we continue to add on all these service lines, just kind of representing this ghost hospital that they built out for us. It's pretty cool, representing that we've almost become a virtual hospital with the amount of services we have and how many patients we touch each day with this type of work. So on average, we're interacting with about 840 unique patients every 24 hours within all these service lines. And to date, since we opened the virtual health center 2016 in very rudimentary fashion to all the way to today, we've impacted 1.4 million lives. And so for UC Health, we often look at just how many lives are we touching, what are those stories, as many of us do and all do in healthcare. And so that's just how we kind of look at that. And when we do awareness about what is the virtual health center, just kind of talk about these touch points that we're here to really augment frontline staff and have to be very thoughtful about how we do that to not be interruptive to their workflow, but be supportive to their workflow where they have pain points, and not just layer one more piece of technology or a workflow that really doesn't make sense to somebody who's on the front lines. And so we keep those kind of guiding principles in mind. I'll switch to the kind of specifically to where we started our journey with AvaSure. If you can go to the next slide. As Elizabeth mentioned, we use their program for telesitting, and we've branded it Safety View. So on the next slide, you can actually see a picture of our command center. And so telesitting, I know, is pretty widespread these days. Some folks are still setting that up, but a lot of folks have adopted this, and it's almost quote mainstream after the pandemic. But this is we currently can watch up to 72 patients in our healthcare system. When we started this work, I'll be honest, I started my role about 5 years ago. Our average daily census was 2. We had a really hard time at the beginning to get change management and buy-in. Did many a road show with nursing about what makes sense for us to watch, what doesn't make sense from a patient safety perspective, what we should never be watching, and really align on that criteria and build some trust and rapport. And from there, it's been gangbusters, to be honest. And so we're actually in the throes of doubling our capacity this year to 144 concurrent patients. So essentially 144 spots that can be admitted to. And one question I often get asked, so I'll just kind of call it out, would be that we have a nurse-driven process. So I know a lot of facilities have done that, but as far as the ordering process, we allow and sort of put it in the hands of our nurses to determine, along with some AI tools that we're using, to say who should be selected for this. And, you know, we love our physician partners, but we feel like this is more of a nursing scope. And so that has helped us to be really successful because nursing has, you know, sort of that control of who they need to admit from a patient safety, and then our AI tools to kind of help guide us of who should be admitted that maybe nursing wasn't necessarily thinking about, but there's, you know, it's showing that they're going to be very impulsive and a good candidate for this type of technology. So you can see our amount of interventions that we're providing here. You know, it's, if you look at it, it's a pretty high touch point for, you know, to help support frontline staff. And we always, you know, another question I always get is, can you make a meaningful connection with this type of technology with nurses? And I always kind of brag that we see the full spectrum of human behavior in telesitting, as you probably have too. And so we've had 2 marriage proposals, the same tech, and then, you know, we've had no marriages to date occur, but it just speaks to, I think, the amount of connection that you can have with patients, and, you know, still finding that human connection, even though you're using technology to do that. So,
Yeah. Amy, I have visited there and I've seen firsthand how your monitoring staff build relationships. So yeah, I love that. But and I see them also. I saw one of your monitor techs interact with a patient who had a bone flap.
mhm.
And he was a big guy and his girlfriend was going to try to help him stand up and go to the bathroom, you know. And so that just like immediately, hey, you know, I'm going to get your nurse to come in and help you with that. And so those are the type of verbal interactions that we're talking about with those 730 interventions every 24 hours. So fantastic program. And there you can tell by the space that it's a lovely space to be in. And I believe they can stand up and sit down, and great ergonomics too.
Yeah, I think at the conceptual phase, we put a lot of thought into, and we traveled around and saw there centers that, or even at that point, it wasn't so much centers. I know like centers have become more in vogue, if you will, but there was a lot of programs that we looked at. And one of the things that people called out as a best practice is, you know, to consider the lighting, that you have control of the lighting. You can have the stand and kind of, especially because it's a cognitive burden to do this type of work, right? It's a different type of mental capacity and fatigue than you have at the bedside, which is just as, you know, they have different, you know, pros and cons of, you know, what those workflows are, but to be considerate of those things. And so we tried to build out those considerations to help with fatigue and keeping people kind of mentally focused and sharp for this type of work. So that was, you know, kind of our earlier days. If you switch to the next slide, where we started to build, I talked a little bit about that we were doing our virtual ICU work in our community setting. We actually didn't start with AvaSure as our vendor out of the gate, but then switched to them and started using them for our virtual ICU platform for camera technology. And from there, we started to think about, we have these expert ICU nurses that are focused on the traditional kind of EICU work. So, you know, at nighttime, an intensivist covers these hospitals. We help support ICU staff. But really, it was a small N of beds. And, you know, what could we start to think about scaling for expert resources? And so in our particular healthcare system, we had a sepsis alert process to some degree, stood up in varying parts, but we did not have providers attached to those teams. And so we started really think about how could we partner with local staff, you know, nursing physician partners such as Dr. Patel, and stand up a sepsis. And then it has evolved to be inclusive of all deterioration. So if you go on the next slide, I'll just talk a little bit about what our workflows look like. And we're using our virtual ICU staff to do these workflows and an attending provider, just to call that piece out. And so I guess going back to Elizabeth and the title, you know, we're using our experts to really scale and thinking about like a rapid resource nurse or rapid response nurse and attending in the sky, partnering with the local resources. So prior to this workflow going in, which was in 2019, the way we approach sepsis, as probably many of you may do as well, is we use the early warning score in Epic. And those flow sheet rows that the bedside nurse would document on, they had to be in Epic, you know, to get the prompt to do it or remember to do it. They would fill out the flow sheet rows. They would then get a BPA in Epic that would tell them, you know, hey, your patient's meeting criteria or to be thoughtful about sepsis. But often they may not, they may put that in and then not see the BPA till later. A lot of times, one of the biggest problems we saw is that the BPA was wildly inaccurate, meaning you would leave one field blank, like mental status or something like that, and it returned sort of I can't figure this out. And so it wasn't really a very actionable BPA. So nurses tended to overwrite it, ignore it. It was just sort of noise if it even, got to that point. But say they got the BPA, they felt like the patient was meeting criteria, they were empowered in some locations to order a sepsis protocol. So then they would go draw a CBC and lactate. It's often a huge delay with them seeing that because they may or may not be an epic if they're a busy acute care nurse, attending to their patients. And then we saw just a lot of variability in the process from there. The expectation or the ask was to activate a sepsis alert when your lactate was greater than 2. And we just saw, even before the pandemic, and even now, you can imagine more, where there's just so much novice expertise on the floor, and even in the ICUs, there was a lot of hesitancy to activate a sepsis alert, just because of, I'm not sure what this means, I'm not sure what the reaction is, I actually haven't seen this often, so I'm not sure. And let me check with my charge nurse, and now we've had like an hour delay because the charge nurse was tied up, etc. So we actually started working with some quality folks, our CQO folks across the system, and said, what would this look like if we designed a virtual process to partner? So we started to look at what tools. Oh, sorry, go ahead, Elizabeth.
Before you go into the virtual process, I saw Dr. Patel like kind of vigorously nodding her head yes. So from your perspective as a hospitalist, were you there before the virtual sepsis? Okay. What were some of the struggles for you on the hospital side, working with nurses who maybe didn't fill out the whole BPA or were hesitant? How did that affect you in your practice?
I think from a physician perspective, it was all about delays in care. None of us the chart all the time, right? We all have cognitive loads, we all have competing priorities. And if you're not in the chart, you don't see that the vital signs are changing. You don't see that lactate in a timely way. You don't know that people are missing elements of that BPA. And so we were waiting until it was really late in the game to intervene on our patients. So the fact that Amy's team can come in, identify the patients early and upstream, and then let us know so that we can start to get the ball rolling on all of our, time to antibiotics, time to fluids, all the lactates, follow-up monitoring for assessment. All of that made a big difference in our patients' lives and our care. And, from my perspective, felt very supported because I know that there's a second eye watching my patients when I'm not in the chart physically because I'm having a goals of care discussion with my patient, somebody else in my patient. Yeah. So, I think it was a huge opportunity, and Amy and her team really stepped up to take care of our patients.
Thanks. Yeah, I think, we started to put together our heads with, folks like Dr. Patel and others to just, for all the points she just called out, like how can we partner and how can we really help? I mean, we still don't want to take away the ability for our nurses to call a sepsis alert locally or a rapid response. We would never want to do that. But how can we help be that second set of eyes? And also hardwire, I think in this, it's now more of a buzzword, but at the time it wasn't as much when we were doing this work initially, but how do you develop a high reliability process so that if it's a float nurse, if it's a traveler, if it's a novice nurse, if it's a nurse who's just having a very busy day, how can we always have the same expectations or support for those folks and same expertise available to those folks? So that's really what we've tried to do with our virtual sepsis. So we looked around and said, rather than using a static score in Epic, are there other tools? And so I'm happy to go into it more, but we have 4 tools that we use continuously in the background, 2 of which are AI, 2 of which are looking at physiological vital sign data, so shock index and another tool. But essentially we have our virtual health center nurses getting those triggers instead of a BPA going to the bedside nurse, which has saved over, I think we're about 3 to 4 million BPAs at this point since we started this program. So a huge cognitive burden off of.
Wait, what about the millions of BPAs avoided?
Yeah, so the EWS BPA that you see in the previous workflow, like before the VHC, that would always go back to the bedside nurse. And so every time they were in the chart, you would get a warning, hey, your patient might be at risk for sepsis, or hey, it's scoring this, can you complete add in mental status to get this to be accurate, and we'll give you a new score kind of thing. And so over, you know, within the first year or so, we'd already well saved over 1 million BPAs that we basically pointed towards our virtual health center staff.
Yes.
Yeah.
Thank you, I'm sure.
Yeah, I know. I have a funny slide that I usually have a meme with a nurse sitting down that says, "This never happens." But yeah, I mean, it's only one BPA at a time, but we all know if you've been an Epic as a bedside nurse, you know, and as a provider, BPAs are very cognitively burdensome and just distract you from what you're trying to do. So they reach out, they authorize the CBC and lactate before any provider has been involved. And if the lactate comes back then too, then we go ahead as nurses at the virtual health center and activate the sepsis alert. We originally went out of the gate with a process where the virtual health center attending would sort of intervene and determine with the bedside provider. And I'll let Dr. Patel weigh in this in just a moment. But we actually, through our outcomes, continue to see fallouts where it would make more sense if we just truly went out of the gate with nursing being empowered to call the sepsis alert. Provider can come to the bedside and call that off if they determine it to be something different or of different origin. But we have seen such an improvement since we did this reversal of the workflow in August of last year for our outcomes, which we'll talk about. But we've seen a huge improvement by just making it structured and really letting our expert nurses, you know, both frontline and in the virtual health center call that rapid response. I don't know, Dr. Patel, what would you want to add in there since you were instrumental when we reversed those decisions?
Yeah, I think change management is always hard, but we went back to the why. You know, it's at the end of the day, this is somebody's father, grandfather, daughter, et cetera. So we want to bring it back to that, improving that patient's life. And, you know, again, I will add, we all have cognitive loads. We all have cognitive, you know, competing priorities. And if I were a surgeon, which I'm not, but if I were a surgical hat and I'm in the OR, I can't respond in a timely way. We're delaying care for that patient significantly. And I think when we brought it back to that why and said, you know, if we can intervene earlier in our patients and recognize sepsis earlier and more upstream, this is a life we could save. And I think after multiple you know, change management techniques, and Amy was part of all of that, we were able to help everybody understand the why. And I agree, I think it was hard in the beginning, but at this point, it is part of our day-to-day. We don't even think about it anymore. It is just an expectation that if a sepsis alert is called, we follow through with everything that's happening at bedside, and we can then step in to say we agree or disagree that this is sepsis, and then can stop the process. But actually, we don't stop the process very often, from what I can gather. Amy, would that be correct? Yeah, correct. I think our nurses are, we're starting to get such good expertise at that bedside that when a sepsis alert is called, it really is sepsis, and we're able to make a difference. We went from over 90 minutes to antibiotic administration down to less than 60 minutes, which is a huge deal when we're talking about impact on life.
Yes, and what I also love is how iterative this is, because when did you start your virtual sepsis program?
Yeah, it was interesting. We were doing it, we got it all rolled out during 2019, and we're just going back to really, you know, iterate, if you will, in 2020 when COVID hit. And so we had just gotten it started right before the pandemic and that year prior, and then obviously kept it going during the pandemic. And it was actually, I think, with all the float staff, the float pool, you know, just all the things that were happening during the pandemic, really gave a lot of support to the people who were floating in, you know, maybe from, I haven't been at the bedside in forever and I'm trying to help, and gave a lot of support that way.
Yeah, so you've been doing this for 3 years, and then last August, you kind of found another lever to pull that just ramped it up. So those of you who are listening, you don't have to go through that. You can start out where, you know, Hamali and Amy have gotten after a lot of years of work. So that's probably worth their hours sitting here right now, just that one thing, because it seems like, yeah, let's see your outcomes.
Yeah. So yes, if you can learn anything from us, happy to share. I'd love to save you brain damage that we have gone through. So our outcomes, so I think people always ask, you know, how is this working, or how is it actually tangibly? And I think what's hard in this space sometimes in a virtual approach, how do you know you're making a difference together with frontline staff? So we've put a lot of intentionality around this as well, because again, we want the virtual health center not just to be additive, but something that really is pivotal and instrumental to improving, outcomes for patient safety and for frontline staff. And if you go to the next slide, we originally saw, because of the tools and the way our workflow just set up, like I talked about, like not having the delay where the nurse had to be in the Epic. We're always in Epic here, at our health center. We found that we are finding sepsis 2 hours earlier, which, if you're familiar with this metric at all, every hour is like, very much matters for mortality. And then what was interesting is that we found that we were finding it 30% more. And I think for the skeptics, right, they're always like, well, was that really sepsis? So these were confirmed cases of sepsis. And so we just found like we had a better tools and a better process to call it earlier and often, and started to see some major improvement in our mortality. Like Dr. Patel mentioned, we went from antibiotics, we were somewhere in like 60 to 90 minute range to get those in. And on average, we're getting antibiotics from time of sepsis alert to, to hanging about 20 minutes or so. So it's a really fast process now with just all the things that we've added in. If you go to the next slide, the other thing this was earlier data, you can see the pre-post period, it's very early, because we started working in 2018 with the pre, and then 2019 as we went live. And these are non-present on admission sepsis cases. So these are typically sicker patients of mortality indexes. So hence why when you look at this, but even in our very early days, we started to see drastically a big improvement. You can see there. And, sort of if the bedside folks had called a sepsis alert on their own without the support versus the sepsis timer and different workflows that we've added on, and it's only continued to improve. If you go to the next slide, this is our most recent sepsis mortality for FY23. The last 2 months are extrapolated because we're not at the end of FY23, but based on current run rate, we're on track to have saved 347 more lives just for the improvement of this past year, to your point of we continuously iterate. So if you look at the top right, our mortality index went from 1.06 in FY22 and we're down to 0.92 as a system. And we've just put a lot of work and continue to put a lot of intentionality around this work, like we just talked about. So
can I ask a question of what is a mortality index? And is that as a system, all the inpatients, or is this just the sepsis patients of the mortality index?
Yeah, on the very next slide, it's I was just going to explain that it translates to 347 more lives, but you're observed over your expected for just for sepsis mortality. We've had an improvement in our performance to say that you walk through our doors, we would have expected you to have mortality, and we've done better than that by 347 more lives. And, our 1.0 just basically says you're keeping with what people, we expected, you're even. You came in, we thought, and it went the way we thought. You want to be under a 1.0 to be able to be, improving care. So I don't know, Dr. Patel, if there's anything you want to add to that piece.
Nope, I would agree with everything you just said.
Yeah, so on the next slide, we always try to quantify everything, and when we're doing especially for our staff, just what does that really mean for patients? It's, when you're a remote clinical command staff, it's sometimes hard to feel that connection. And even on the front lines, you feel like you're running around like, is this making a difference? And so really this work has saved, even just this past year, 347 more lives. And so that's, one more dad or mom or loved one that's walked out the door that we're just so proud of. So from that, we've really kind of spun up then and getting more intentional around, well, we're focusing on just sepsis, and that's one form of deterioration. But how do we hardwire, if we can, all deterioration as far as rapid responses? So I'm actually going to turn over to Dr. Patel, because we've partnered on a kind of our next phase, which has been virtual deterioration. How do we take it a step further than just sepsis? So I'll turn it over to her.
Thank you. This is a highlight for me because I think this program is so impactful for our patients. How do we take our data analytics tools and the AI tools that Amy talked about and identify patients who may be clinically deteriorating more upstream in their hospitalization when you first see that sign, rather than waiting until it's really late in the game, and then partner with the bedside team to really deploy standardized interventions and treatments through our rapid response teams. The goal is to call RRTs as often and as early as possible to help improve our patients' lives and safety and decrease mortality. The pilot, if I remember correctly, Amy, began on 2 units at 1 hospital. It has now scaled up to 12 hospitals for the acute care and progressive care units, which is a huge deal. Next slide. So part of the process and part of the deployment of this program is really building, designing and then implementing a highly reliable deterioration workflow. We had to be really thoughtful about saying, what are the criteria that we will use to activate the RRTs, who's going to do what, because otherwise there could be a diffusion of responsibility if we're not very clear. So I had to really take time to say, what is a virtual health center responsible for? What is the bedside team responsible for? What is the physician responsible for? And be really thoughtful about the standardized interventions that we would have. As part of our RRT, as we deploy the RRT, what we actually do is we bring in a camera so that the virtual ICU nurse is able to observe the patient during the RRT, but then actually even observe the patient 6 hours after the RRT is completed. And this is extremely important because we know our bedside nurses have competing priorities, right? They have other patients that they have to go and take care of. And so they're not always monitoring the patients continuously. And this allows us to really monitor the patients continuously. If I remember correctly, it took a few iterations. We actually did this without the camera first and wanted to be a little harder and less effective because we weren't able to engage that directly with our, not just the bedside team, but with our patients. And so eventually came to the conclusion that the camera really does make a difference for our patients and monitoring. We do have exclusion criteria, just like any other good program. If patients are in comfort care orders, we do not activate this process. If the changes in vital signs are non-sustained because somehow the oxygen came off on our patient and we put it back on and they improved really quickly, for example, or if the bedside team is already intervening on the patient and their vital signs have returned to normal, then we won't activate that. But otherwise, the goal is to really activate this for every patient showing signs of clinical deterioration. Amy, anything else to add before I move on?
I would just say, I think what seems to step, at least to me when I look at this, if I'm not as in the weeds of it, I think what's hard about deterioration is how do you get a high reliability process when you are going to activate things? Dr. Patel and I have been looking at this a lot as far as Kaiser's done a lot of work with this. That's been really notable. Mayo, I think, has done a lot of work around this, but it's a really hard space that's so gray of how do you really take it and make it tangibly and tactics you can do to actually make it hardwired. So I just echo that. I think what Dr. Patel is calling out, all these things sound very, I think sometimes obvious, but they're not obvious when you look at case reviews and mortality reviews of well, what was going on here and why weren't we intervening, or what Swiss cheese sort of played out here. So I think that's just been a lot of, sometimes when people aren't as familiar with this metric or this space, it's well, yeah, but until you really get into it, it is very hard to get this hardwired with frontline nurses and responding folks.
Yeah, and I would argue that it's the same for our physicians. Anytime an RRT is called on our patients, it does feel like we failed, right? That we missed something. And so how do we actually engage in that culture management and the change management with our physicians so that we recognize this is not a failure of care, that this is an evolution of a patient's condition, and that the goal is to just deploy all hands on deck to take care of that patient rather than you having failed as a physician because you didn't do the right things. And that, I think, took us a while, and we're not going to minimize that change management part, but I think that that's the goal, is to bring it back down to the why. It's about a patient's lives, and it's about the evolution of a clinical condition changing over time, and that we want to help you take care of your patients while you are in the operating room, while you are in a procedure, while you are in another patient's room taking care of that patient. And so it's a team effort there.
I am so intrigued that you said that. I actually hadn't thought very much about that before, Dr. Patel, that as a physician, all of a sudden you hear a rapid response when called on your patient. You're like, oh, that's a failure on my part. That's just really important cultural piece to point out. If you go to the previous slide, go backwards one, And you touched on something, Dr. Patel, and I'd love, Amy, for you to expound on it a little bit, but the importance of visualizing the patient in the camera versus just doing this on the phone. And you can see here over that virtual nurse's left shoulder is the video application, the AvaSure Verify. And so she would be able to click on any of those 38 thumbnails. And when I've been there, like the rapid response patients that they're monitoring for 6 hours are kind of grouped together, and they're able to intervene. So how did that make a cultural difference, do you think, that visualization piece?
Yeah, we went out of the gate with that workflow Dr. Pell was showing, where we look for kind of holding the bundle. We tried to apply the same idea that we had done with sepsis, and we have timers and track boards built out, and Epic Monitors, our tool we use. And what we found though is we're making bunches of phone calls. So if I'm remote, I can't see what you're doing. I can't see the patient. And we got the idea because we had been using the technology AvaSure in our virtual ICU, and in our community hospitals, we have all the cameras installed in the ceiling, and so they're not mobile. In our quote older facilities, if you will, we have mobile cameras, so we have both platforms. But they just love the ability that they started just doing it informally, where they could beam into a med surg room and see that. And it was such a valuable tool, and it cut down on the friction of, hey, are you drawing labs? Well, yeah, I actually am sticking the patient and you're calling me while I'm trying to do my job. And that actually led to some friction in the process. You can imagine it's annoying to be getting a phone call like, are you giving the med? I'm hanging the med. So it just feels a little, duplicative. So what we do now is we have the rapid response initiated by the virtual health center and frontline staff, both can do it. And then there's a camera brought to, if it needs to be mobile, a camera brought, and or we can beam into that room if they have a ceiling camera, and that's the expectation. And once we started that, it was pretty much a game changer in the sense of, I can see what you're doing, I'm not having to constantly interrupt you. And then the biggest piece that we've seen an improvement in, and we've had really good patient saves from this piece of it too, is the virtual ICU nurse won't continuously monitor them post rapid response, but keep that thumbnail up and do periodic checks on the patient. Yeah. And so we've had some really good wins where we helped a patient who was going to potentially aspirate, where post-ictal, post-seizure, virtual ICU nurse was able to kind of tell the bedside nurse, because the rapid response nurse had left in person, what was going on, what to do, and hard to prove a negative, but save them from, put a yonker, get suction hooked up, put them on their left side, all these things we should do to keep our patients safe and help the nurse. And what we've heard loud and clear is that the frontline nurses in acute care feel so supported through this process, because they're novice and hungry sometimes for that mentoring and just that, what should I do? I need help right now kind of thing. So we found a huge improvement once we started adding in that video component.
And when I was an ICU nurse for many years, and I had a great preceptor early on, and I would walk in the room, and you want to look at the tech, you want to look at the vet settings, you want to look at the physiologic monitor, you want to look everywhere, and she said you have to look at the patient because the numbers can look bad but their color looks good, they're not sweating, and vice versa. So being able to also see the patient and leverage that expert experience, which you almost do by the time you're as experienced as these RNs are, that you're almost doing intuitively without even consciously knowing what it is that you're seeing, like boom, 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 I'm seeing these visual cues as well as the numbers. So
yeah, we trend a lot of the data back to the local rapid response teams too. So for instance, hey, I just rounded on bed 6 who just had a rapid response an hour ago. They are breathing, they're just not looking well with their breathing. It does look like they're going to need to be intubated. Can you swing back by and we'll potentially call another rapid response and get the airway team there. Things like that. It becomes very, you can just sort of lay eyes on the patient quickly with this type of tool.
Yeah. Sorry to take you out of your flow. I think we were about to go a couple slides ahead to your outcome. So there we go.
And, you know, I think our outcomes speak for themselves. The goal has really been to cover all 12 UC Health hospitals with about over 1,800 bed scope, and have really started to move the bar in calling our RRTs early and often, decreasing the transfer to higher levels of care, increased monitoring post RRT. But I think the most impactful is really looking at those code blue events, and we've really made a difference decreasing those code blue events up to 40% in some of our hospitals. So, you know, as we talk about patient safety, as we talk about making an impact, this is what matters. Next slide, please. And I think when we are looking at outcomes and our data, let's look at mortality as a whole. Again, bringing it back to that index, just a nice show of how it's starting to drop as we've started to make an impact across our health system. You know, a goal again is calling our RTs as early and as often as possible so that we can impact mortality. And I think we're seeing that dramatic change. We've gone from being in the top 50th percentile for our mortality to now being in the top 25th percentile, and can connect a lot of the interventions that Amy and her team have done to our mortality index. The other thing I think is important to highlight is that this is not a one and done. I think Amy and her team really continuously optimize and iterate upon the process, and looking at triggers and tools to recognize the deterioration earlier in the hospitalization. Next slide, please. And as we look at our data, right, we looked at our sepsis data, 347 lives. Well, if we look at mortality as a whole, it is 786 more lives saved this year. And I think that alone speaks to the impact of the program, that sharing of responsibilities and partnering with a centralized workforce at the VHC with a bedside team has made in our patients' lives. Next slide, please.
Yeah, and while we were preparing for this, Amy called it, you know, it's between the two, it's like more than 1,000 patients walking out the door that wouldn't have walked out the door. And almost everybody who's on this webinar today has a clinical or nursing background, is you know, and that's why we go into this profession. Is and I was just driving this morning to work, I was remembering it was probably more than 10 years ago, and I was a clinical nurse specialist in the cath lab, and we had just replaced and upgraded our defibrillators, I think, to biphasic defibrillator. It was, you know, we had just done a major improvement on our defibrillators, and I had done that. I remember going around and doing the training on it, and then we had a patient come in who was a man in his 40s, and we ended up having to shock him. I can't even tell you how many times we had to shock him during the procedure. And because we had just upgraded our technology and had the right technology, he survived. And he wouldn't have, I don't think, with our old technology, because it was just a god-awful amount of shocks that he needed to get. And he walked out the door with his kids and his wife the next day. And that was kind of life-changing for me as a nurse. So when we talk about, you know, 786, 347, you know, those are individuals, and I love that UC Health always comes back to the lives, which is, you know, more important. But you also have to have the graphs and the charts, and you're doing that too. But so thank you for reminding us about that.
Mm-hmm. But I mean, I think it kind of brings us back full circle where we started, where, you know, we have other programs that we're lining up that we continue to scale, that we're, you know, both kind of in early phases and also stuff we're conceptualizing as well. So we continue to build on, and really are just trying to get pretty intentional. I think we've already started a journey, but as everyone, you know, with healthcare redesign, and really because we don't have the right amount of staff, or, you know, have a hard time achieving that, how can we really augment and make everybody top of scope on acute care and other areas as well? But we struggle a lot with acute care just because of the nature of it. So we continue our work, and you know, thanks for letting us share this and kind of a little bit of our journey, and hopefully again people can benefit from some of the brain damage we've had to do, and don't have to reinvent the wheel, and can just start with if there's any lessons learned for them.
We won't say brain damage. We'll just say it's been iterative. There've been process improvements. We do have a few questions. Somebody just said, what a great presentation and great outcomes. Thank you for sharing. One thing you did show that you had, I think, it's covering basically about 18,000 beds. So how many nurses are, that ratio is always a question that comes up.
Yeah, I forgot to call that out. I usually do. For our 1,800, so like we mentioned, we're covering, for virtual sepsis and deterioration, we're covering all of acute care, PCU, and patients who are boarding in the ED that are, inpatient status.
Bermuda Triangle. Yeah, boarding.
Mm-hmm.
Yeah.
Yeah, we got asked to extend our programs into those areas quickly just because of the exact reason we all know. But it's 3 to 4 nurses on every 12 hours. We have nurses who do this as a full-time job, and we have nurses who job share as well. And then it's 1 attending for our clinical command center who's wearing many different hats, including being the provider that helps with these cases, in conjunction with the frontline staff, the rapid response team, and responding folks as well. So, but typically 3 to 4 nurses and 1 attending is our complement to do this. So it sounds odd, but they're covering about 500 to 600 beds. But the reason is you're surveilling, you have your tools in the background, and the patients are only coming through if they're showing potential signs, then they're doing a review process. And so it's kind of a funnel, right? We get all those BPAs pointed to us, if you will, and tools, and then funnel it down. So that's how we're set up.
I think that just sharing that with those who are listening, who are in the conceptualizing phase, is extremely helpful. It's like, okay, this is where we're going to start, roughly staffing wise, and then go from there. So thank you for sharing that. And then in a related question, how do you recruit the nurses who are the experts, and what qualifications do they need?
Yeah, so we we want a minimum of years ICU experience, 2 years at least of bedside. And then we tend to look for folks who have had experience in precepting and or rapid response team, preferably rapid response team experience, because basically you're a rapid response nurse in the sky here. And you're also teaching. There's a big component, I think, that people think with this type of work, I don't know how to explain it, but that I think the customer service and the change management is so important. You really need a partner to the nurse and a teacher. You're not there to sort of audit people or big brother or, have that kind of mindset. And I think that's a temptation sometimes in this, you have to be careful about how you're really setting that tone. And then we tend to have really good retention. Everyone always asks me about this, but I was actually just thinking about this, and I'll probably jinx myself, but we've had 0 turnover in our virtual ICU nurses in the last 2 years. I mean, it tends to be a job that people really enjoy, a small team that's really well connected. And so it's just, we tend to retain people, and we've had really good interest with job shares. It's about 25 to 30% job shares, and then the rest, staff who want to do this full time. So it's been successful in that regard.
That's a great idea of job sharing. And I was able to shadow in your virtual ICU, I think it was last fall. And that's what impressed me too, Amy, is their communication style and not auditing. And the nurse was kind of talking out loud so I could understand her thought process, the virtual nurse. And there were a lot of times when she was deciding not to interrupt, to wait, to communicate through WeChat or something. And so it was a very a high level of emotional intelligence that she was using about how can she mentor and be supportive. So and so here's a question, and I'm gonna, I'll let you answer it, but somebody said, do you utilize light duty staff in this role?
That's also a common question. We do in our virtual command center. We will use them a lot into some of our roles that are easier, like virtual urgent unit clerk, virtual urgent care unit clerk. Even within Safety View is one that will rotate light duty in. To be honest, unless it's an ICU nurse who's going to be on light duty for a long period of time, like 3 months or more, we don't use them in our virtual ICU because our workflows, it takes a while to learn them. And it sounds like it wouldn't probably, but I think just because we're authorized to activate, we're pretty much predominantly activating all the sepsis alerts, starting to activate more and more rapid responses in conjunction with frontline staff, of course, and all these workflows. But they're a little too complex, and the Epic monitor tools tend to be overwhelming for people if they're not be with us for a period of time.
Yeah.
Is how we approach it.
Yeah, I think it's fine to say, you don't know, probably not. Because I think that the right person in the role can make all the difference. So just to randomly take whoever has had knee surgery just might not be, it might not set you up for success. So great question.
Yeah, it tends to intimidate people, to be honest, to cold call, like if when you're reaching out to primary nurses, and it just feels a little bit awkward until you get the swing of it, and you're making a lot of contact each day. So there's definitely an art to it, like you're calling out.
Yeah, I'm just going to finish with one question, and then maybe we can leave a few minutes for people to get ready for their next, online meeting. But what challenges did you face back when you decided to kind of expand beyond safety sitters into virtual nursing? And how did you kind of build a momentum with your leadership and become early movers in this space?
Yeah, I think top-down change management and bottom-up change management are so key. You need top-down support and buy-in from senior leadership, but that alone won't get you what you need. And you bottom-up, but again, bottom-up without senior leadership won't get you what you need. You need both. And then just having tons of relationship building. Like for instance, before we launched virtual sepsis at the Anschutz Medical Campus, or academic campus, which is a large campus, many service lines, very specialized patient populations. We met with 15 different, maybe more medical directors of each area to say, how does this program going, here's our program, how does it intersect with your patients? Tell us about your patients. And of course, everyone's patients are special, and those kinds of things, but they are special. So how do we account for the differences, but yet keep a high reliability process? So I just think it was all those efforts, to say it succinctly. I don't know, Dr. Patel, is there anything you would call out differently or add to that?
I think, so I would agree with everything you just said. I think the other piece is the commitment to hearing people's feedback. I think that makes big difference. So it's not just when you start, before you start, but as you're starting, having that commitment, I think has made a big difference. Amy and I review, Amy and her team, and then I review every single case to see if there was an opportunity, especially if something did not go well, and then share kudos when things do go well, and sort of building that culture moment by moment when it's first beginning, so that people understand that there is an oversight, that we're not just one and done, and that we are committed to changing if we need to change as well. So building that matters.
I think iteration loops, feedback loops are really important. You can never be done. You're never done. None of this work is ever done.
Yes.
And that is huge for this type of work, and not just giving people lip service, but following up, like Hamali was calling out. So I think those have been key to, and early adopters, right? Find your folks who are going to be your champions and help showcase those wins right out of the gate, so that it kind of catches fire and it's in vogue,
Yes. Thank you both so much. I've just enjoyed it, and thank you what you're doing for all those lives.
Thanks, Elizabeth. Appreciate it.
All right. Bye.